short here. So good morning, everybody. Welcome to our sixth meeting of this year. Today we have the pleasure of Dr. Lisette Delgado Sanchez, which is well known in our community. Actually, she's been in one of the most famous magazines here in Naples. That was the Latinos. That everybody can look on that magazine. It's a very, very nice article, the one that they published about her. And not only that, she's my personal doctor, as well as some of the patients over here. She has been with me throughout all my ordeal, okay? Since the beginning to still, she is still my doctor. So thank you so much. And before we start, let me just give my gratitude to Lauren Ponce and Oscar Escobar Jr. They're the ones who provide us with the snacks today. Our gratitude to the club members, all the ones that have contributed throughout this time. All you know who you are. Thank you so much for your contribution. Believe me, all that helps. Every little thing that you provide me with helps to make these meetings and make this club possible. My gratitude always to the Naples Pulmonary Rehab from NCH. They do a fantastic job for all of us. Okay? And with that, I don't take any more time. I just want to give it to Dr. Lisette Delgado. Thank you so much.
Thank you. So I think I'm gonna not use the microphone. Can you hear me all right if I say? Okay. So I want to also thank you all for being here and for giving me this opportunity to talk to you and for Oscar to convince me to prepare this presentation that I did for you. One of my patients, I asked her and she told me, I would like to know a little bit more about COPD. So I did a presentation about COPD and we will talk about it. My name again is Lisette Delgado Sanchez. They call me Dr. Sanchez because at the beginning they thought my Delgado last name was my middle name. So, but any of the names works. And sometimes when I get excited, it sounds that I'm speaking Spanish. So please do a sign or something. I know what is happening. So the agenda will be what is COPD, how it develops, how the symptoms forms, what can we do to make it better. So I wanted first to show you what is the basics of where the COPD forms. That's the respiratory system. And mostly when I'm going to speak some words, I want you to understand. The lungs work to get the air in, and so you get oxygen that is necessary to obtain energy in your body. And then the CO2 is part of that extra of the metabolism that needs to be exhaled. And all that interaction of gases is done at the lung level, at the very, very small level of the lung called alveoli, which is the smaller of all of the units in the lung, and is a very, very thin membrane surrounded by vessels. And when the air gets there, it's easy to interact with the blood gases. And then, of course, that's the lung. The right lung has 3 lobes, and the left 2, mostly because the heart is towards the left and it kind of takes a little bit of space from the left lung. And then you have the main airways or bronchs, which are the tubings that get smaller and smaller until it gets to that very, very tiny unit, which is the alveoli, to get there in and out. And then to get the air there, we need a lot of muscles. We use more muscles of what you think. We are used to it because we breathe maybe 16 to 20 times in a minute, average, and then you don't realize, but you're using a lot of muscles. Maybe people that have a lot of problems breathing, that's when you start feeling tired because your muscles are overworking. We use muscles from the neck, the chest, anterior and posterior in the back, and muscles in between the ribs. The diaphragm, which is a beautiful dome-shaped muscle that divides the chest from the abdomen, and also abdominal muscles that are used to help with exhalation. So all that is part also of the respiratory function. So what is COPD? COPD is when there is damage at the level of the alveoli and also at the level of the airways. And it's called Chronic Obstructive Pulmonary Disease. That's what it means. And it's formed mostly by two main issues, emphysema and chronic bronchitis. Emphysema will be the progressive and damage at the level of that little alveoli that it gets so damaged that it starts breaking. And when it breaks, it coalesces and forms more and more sacs of air, but it doesn't work as good. And so you have now a ball or bulla of air accumulated in the lung that is not working. And then also part of the chronic bronchitis, which is the inflammation with remodeling of the airways, where the airways start becoming more like smaller. And so the lumen or the inside of the tubing becomes a little bit more narrow, and that makes more difficult for the air to move back and forth. Those two components are the main part of COPD. Some patients have a combination of both. Some patients have more one than the other, but both form part of the COPD, and it's usually an irreversible damage in the lungs. So I want to mention with that what happened with emphysema. As I was telling you, the alveoli or that little unit gets broken and gets coalescing areas, and these bullas or balls of balloons of air form and accumulate air because they don't work as good bringing the air out. And the diaphragm, which is part of very important muscle of the breathing, start becoming more flat, just because there is more air pushing down on it. The diaphragm functions this way. You breathe in because part of the other muscle, but the diaphragm, it contracts and it pulls air in. So now you have a more flattening diaphragm, and the breathing becomes more difficult. For people that have normal lungs, I would say it's almost a sensation like if you take a small breath in and hold it, and now you take another breath in. That's the way that a patient with advanced COPD will feel every single time to breathe. Because of the diaphragm not functioning, it's a lot of effort now because there is just a little bit of room to work, and then you need to use more of the other muscles to make it better. So what are the causes of this? The main problem is smoking. Throughout the whole world is the main cause of COPD, but there are a lot of other causes. Secondhand smoking, occupational exposure. This is associated to a lot of works. For example, people that works in mines, people that are exposed to silica with like stone cutting, some farming, for example, people that are related to industrial collection of cotton, of corn, wood, some chemical industrial locations, even, for example, people that are associated to welding of heavy metals are also exposure to some chemicals that they breathe and can be also a cause of COPD, biomass exposure with the environmental pollution, and of course, genetics, for example, alpha-1 antitrypsin deficiency. So that explanation of how it forms leads to a lot of symptoms, and that will be mostly shortness of breath, cough, sometimes a lot of mucus, phlegm, wheezing, and with that fatigue and less activity possibility. I wanted to add this graphic of a smoker and non-smoker and how COPD develop when you smoke. And there is in the lung function here, and this is time. And like everything in life, the lung function goes down over with time. So maybe if we were to live 200 years, eventually we will catch up with the lower part. maybe. The thing is, when you smoke, your lung function goes down because of the inflammation that develops and the emphysema and the bronchitis. And this is a kind of a graphic of how it goes much faster down, and you will start having symptoms, usually more commonly between 50 and 60 years old. Well, if you stop smoking at any time of that decline, right there and then, your lung function decline stops, and it save you time to get worse. So people that say, I've been smoking since I'm my 7 years old, I know it's difficult, but we always mention that so much because right there and then, it will make a difference for the future next 10 or 20 years. Some people that stopped smoking 20 years ago start telling me, but I stopped 20 years ago, and now they have a little bit of symptoms. I told them, eventually catch up with you, because even if you stop smoking, it can lead to some symptoms at sometimes down the line, but it still save you quality of life, and it still save you lung function. So the COPD with this inflammatory response that is caused because of this inhalation usually and of chemicals is not only a problem by itself, has been proved with inflammatory markers that develop and are higher in your levels and in your blood that are associated to more in these patients of osteoporosis, chronic anemia, diabetes, depression, muscle dysfunction, cardiovascular disease, etc. So it's not only important to treat and avoid COPD, it's just because the morbidity or the comorbidity that comes with the COPD is higher the more or the worse that COPD develops. And that's what happens. Patients are feeling shortness of breath. They do less because they feel shortness of breath. They get more weak. They do less. And then it's a spiral of negativity. Then you get much worse over time. So what is the population at risk for COPD? It's based also like in the main reasons to cause this. And believe it or not, in high-income countries, women are actually highing out on the prevalence of COPD lately by statistics. Smokers, of course, early life issues with asthma or inflammatory diseases of the lungs, alpha-1 antitrypsin, occupational exposures, as I told you, and also in low incomes, classes and prior infections or asthma over time. This is an example of a very advanced COPD. A trained eye can see COPD, maybe not too advanced, but I just wanted to show you an extreme so you can see how much damage can happen. This here on the right is a classic smoker emphysema with bulla. You can see a big balloon of air. That lung is barely working. There is no lung there. It's a big push of air that is not moving. And it's classic for emphysema of the smoker to be in the upper part of the lungs. While the left side is a non-smoker patient, and yet you have more of that kind of bullous, of course, not as extreme, but you can see it right in the bottom of the lungs. And that is classic of alpha-1 antitrypsin deficiency. The pattern of the emphysema is different because the pattern of how it shows or how it forms is different. And so why is that happening? The alpha-1 antitrypsin is a protein that kills another protein that is trying to defend the body against damage. That protein comes and tries to kill bacteria if it comes along. And the thing is, the alpha-1 is trying to keep an equilibrium because that protein that is trying to defend your body against the injury is also attacking your own cells and damaging the lungs. While what happens with the smoker is when you smoke, because of the gravity, most of the blood is in the lower part of the lungs. Most of the air comes on the upper part. Of course, you get air all over your lungs, but most of the air of those chemicals that you are inhaling, like tobacco or environmental, most accumulates in the upper part of the lungs. There is less blood compared to the lower part. So now the cells comes to try to fight against that, There is also alpha 1 trying to defend, but there is less blood. So there is not enough alpha 1 to contrarrest the damage that is happening in the upper lungs, and you get more emphysema in the upper lungs when you're a smoker. While you have an alpha 1 deficiency, again, you have more blood in the lower part, and so there is more neutrophils, which are the ones producing this protein called elastase that is trying to defend the body, but there is no alpha 1. So more damage happens in the bottom. And that's the physiology, why they are different. Both of them is the alpha 1 and the elastase equilibrium, broken because of different reasons. The statistics of COPD are very alarming. Is one of the main reasons of death worldwide, and many people remain on diagnosis, and is expected to continue increasing the amount of people with COPD, even in countries actually of low and medium income, even higher than in the United States. So how to diagnose COPD? Well, the main thing will be a spirometry or pulmonary function test. Everybody here probably is familiar with PFT when your doctor tells you, which is called pulmonary function testing, and that's a test where we can measure the vital capacity and the lung volumes and the diffusion capacity of the lungs to work with the gases, a CAT scan, oxygen testing, and of course symptoms and history from the patient. This is an example of a PFT. It's too technical. I just wanted to show you the difference. The little ice cream cone on the left is a normal breathing test. When we make you breathe in, that will be this round in the bottom, and then you need to blow out, and that first second is very high in volume and goes down over time. When you have an obstruction of the airways are closed and inflamed and chronically damaged, then now the tubing is not only in the main tubing. Remember, this is a tree of airways throughout your lungs, all adding resistance throughout. When you are taking a deep breath in on the right one, you see the inhalation, and then when you blow out, there is a pattern of resistance, and that makes the classic picture of the spirometry for a patient with COPD and obstruction on the airways. And that's why we can measure the degree of obstruction or tightening of those airways chronically. And that's called FEV1, but it's too technical, so I'm trying to make it understandable. The thing is that FEV1 measurement prediction is very associated to more symptoms. So the lower you have that number, that means the more obstruction you have, the more symptoms a patient will have. This is also a CAT scan. As I told you, it's also diagnosed by CAT scan. The one in the right is a normal lung. The one in the left is an emphysema patient. You can see the little holes, of course, not as extreme as the one I show you, but that is a classic centriacinar emphysema, where there is damage at the levels of every one of those single units of alveoli in the lung. So it classifies, it depends of the breathing test, and it depends of the symptoms. There is a gold initiative, which is a gold initiative for chronic obstructive lung disease, and that is calculated from 1 to 4 based on your breathing capacity. And then, next, it depends of your symptoms. It used to be calculated before A, for the patient asymptomatic or very little symptoms, B, C, and D. Nowadays, is calculated in A or B, which is low symptoms or many symptoms, and then E, where the patients have more symptoms, but it's based on eosinophil count. Here should be less than 150. I'm sorry, that was a mistake writing that. But why that's important? Because few of the new therapies in COPD that I'm going to talk later on are associated to the amount of those cells called eosinophils. And there are injections, for example, now biologics that target that type of cells, and that's why they make a difference. But then it continues being 1 to 4, 1 be the more light COPD, and 4 the more worse than COPD where your capacity is lower. COPD exacerbations, what it is when at the baseline of symptoms, patients start having more shortness of breath, more mucus, more cough, and it can have fever or requirement for oxygen at some point, and that happens because there is, on top of the chronic inflammation, more inflammation. Sometimes there are infections associated to it. And why is important to know that? Because COPD, as I told you, over time, the lung function goes down. But when you have exacerbations, there is a fall in your lung function. You can get better, and it takes time. If you add another exacerbation soon enough, it will not allow you to go back where you were before, and your lung function only will keep on getting worse in a very more shorter time that is required, and also will make you recover even more slow. So that's why it's important to control exacerbations, to know what patients have more or less, because that makes a big difference. So what are the therapy targets nowadays? The therapy targets are indeed trying to decrease all the symptoms, improve the quality of life, decrease the exacerbations, because as I told you, that might make a big difference down the road for the patients. And so there are basic on opening the airways, decreasing the mucus, targeting the inflammation, optimize the metabolic activity of the patients, avoid and treat infections quickly, and strengthening the muscles, checking for oxygen if required. All those components are part of the therapy. And I'll tell you first, and then I'll give you a graphic of all the medications, but of course, then it's important. Number one is smoking cessation. As I show you in the picture how a smoking cessation can make a big difference down the road for COPD. There are inhalers and pills that can be associated, that can be given to improve or target what I told you before, inflammation, bronchodilation. Oxygen therapy, when it's indicated to keep O2 saturation above 90%, sometimes it's on exercise, sometimes it's at night, sometimes it's all the time, but it's important to evaluate pulmonary rehabilitation. Very important. I'll talk about it at the end. Ventilatory support is when those patients that have very advanced COPD, sometimes not only they have low oxygen, they actually retain CO2. They cannot exhale the CO2. The ventilation is so compromised that they live on a level of CO2 that most of the persons could not even survive. The body has been adapted to it, but then they have a very low threshold to go into coma, for example, if the CO2 continue accumulating. And those patients sometimes require a BiPAP or a ventilator at home where they can sleep at night or use as needed, just to help that diaphragm and those muscles to move air back and forth. And with that, you have a lowering and more stable level of CO2, and that makes a big difference for those patients. And of course, part of the rehab, exercise, nutrition, and sleep and mental health. There are other therapies also nowadays. There are biologics, which usually are injections now. There are 2 approved and many more that I'll speak in research on that target of inflammation at the level of the alveoli. There are surgeries. There is something called lung reduction surgery, and is when you remember that CAT scan with that big bulla of air that is not moving, if we actually remove that bulla out, that diaphragm will go up. And now you have a diaphragm that can move better. And that actually, even though you're removing a piece of the lung, you are improving lung function. And that's more or less what the endobronchial stents do, or supposed to do, is without going into surgery, then you kind of put some stents in some areas of the lungs. You close that area of the lung, and closing the area, that lung that was completely expanded and the diaphragm was tight, if you close an area, you allow that diaphragm to finally say, okay, I can go up. And if it goes up, it can go down better, and you obtain an improvement in the lung function. Of course, alpha-1 antitrypsin replacement, I will test all of my patients because it's rare, but it makes a difference when you can catch that patient. Unfortunately, There are some patients that smoke, and they come to the doctor with COPD, and everybody will just blame on the smoking. Those patients have to be checked too. We have found patients in their 80s with deficiency of alpha-1. They were smokers, they were never tested. And that test could have made a big difference for the patient and much earlier in life. And of course, lung transplant, which definitely can happen for COPD. I have at least one patient with both lung transplanted. He is already now 10 years this year with his lung transplant. It changed his life. He did it in his 60s. He barely could walk, and he has 10 years of good quality life. And it makes a big difference actually for COPD. Even one lung transplant makes a big difference. And of course, a lot of research options in progress, and coming right at the door, something called precision medicine. And what is precision medicine actually? Now with AI, every time we're checking more into genetics. And it's already kind of getting into some medications, some diseases, but we have been finding that there are people that respond better to a medication than others. And usually that at the genetic level, you have enzymes that can catabolize that medication faster or slower. And that makes a difference sometimes to choose one medication will work better for this patient or the other. That eventually will come for COPD too. We go now by clinic. Okay, that didn't work for you. Let's try this other. But that definitely will have probably a genetic base. Again, important smoking cessation because that makes a big difference on the lung function. And then we have all the pharmacology associated to COPD. There are the bronchodilators, which goes to the muscles to relax the muscles so the airways open a little bit. That will be maybe the albuterol, the levabuterol, the formoterol that you probably have heard about it. There's the muscarinic receptors, which help with decrease the mucus, helps a little bit with the dilation. There are the anti-inflammatory medications. This is a new medication, unique on its own. It's a nebulizer medication. You might have heard called Ohtuvayre, and it's a PDE3 and PDE4. It's an anti-inflammatory medication that works at the inflammatory level. It's indicated mostly for patients that are optimized on inhaler and are still having issues of shortness of breath and exacerbations. And there is a PD4 that is pill called roflumilast. There is the steroids, pills or inhalers that we use. And then the two on this left corners, IL-4 and IL-13 and IL-5, those are biologics already approved by the FDA, which are injections. They are indicated for patients with eosinophil count above 150 or 200 with exacerbations frequently. And so this injection has been proved to decrease exacerbation recurrence. Remember that we talk about how important it is to avoid that recurrence of exacerbations. There are two more markers in process of study. IL-13, which we proudly participate in one research that already closed, and TSLP, which is another marker of inflammation, even above the eosinophilic pathway, that we will have a research very soon on. And of course, rehabilitation, oxygen requirement. All those are basically, in a nutshell, all the therapies available for COPD right now. And then, Dale, move. Oh, that's it? That was the next one? Okay, just in case. And then I wanted to mention about pulmonary rehab. Pulmonary rehab have been proved to be, of course, the most cost-effective therapy because it has been proved to improve mortality after hospital admission. It has been proved to actually improve hospital readmissions. And patients on pulmonary rehab has better sleep quality, better anxiety and depression, and better health-related quality of life than patients that don't do pulmonary rehab. Unfortunately, sometimes we recommend the pulmonary rehab so patients don't want to participate, but we work hard on that. But that's why it's important. And then that's based on your breathing techniques, your strengthening muscles, your training of strength, flexibility. All that part is like a comprehensive kind of therapy. You know that better, but I'm just mentioning that. And of course, nutrition is very important. This that I put here has been actually proved in the medical literature to improve some outcome in COPD. Mediterranean diet has been proved to make a difference for COPD patients. So it's a diet high in fruits, vegetables, fish, nuts, whole grain. So a more healthy diet. Decreasing of processed meat is actually very good because it's associated when you take it with increased COPD risk and exacerbation. Fruits and vegetables, protein and energy supplementation, omega-3 fatty acid, vitamin D supplementation, antioxidants like vitamin C, E, zinc, and selenium. Target BMI, it means patients that are very, very thin because of the metabolic. Usually patients with emphysema sometimes tend to lose a lot of weight because it's a lot of strain on the metabolic energy expenditure. It's important those patients to have a good caloric support, and the patients that are too obese or very high BMI, which is body mass index, to try to get closer to normal. That will help with the breathing. And of course, meal strategy for patients with very advanced COPD where the diaphragm is flat. You should not fill out your stomach too much. It's better strategy of smaller meals frequently to get the caloric intake and yet digest better. And of course, all that combined with exercise. So these are all the targets right now on evaluation for COPD. So there will be so many medications, we'll get crazy. But there are a lot of targets of markers of inflammation right now in process of research. Some of them more advanced than others. Some signaling pathways of inflammation, of mucus production. And all this is not only to improve the patient, but also if we catch it early enough, avoid that damage to keep on going because, as I said before, it's irreversible. So I think that's it. Thank you so much. If there is any question, yeah. Thank you.
Anybody has any questions?
Can you explain exactly what is an exacerbation?
An exacerbation is when you, at your baseline, you have symptoms already. But exacerbation, the patient will see one having more shortness of breath, more cough, more phlegm, maybe wheezing. It's a pattern where from the baseline you go down. And it's different in every patient, sometimes associated to an infection. We treat the infection even if we cannot prove it, just because it could be very in the background. But exacerbation is an acute worsening of your baseline symptoms that cannot be explained for something else.
Thank you.
You're welcome.
Anybody else?
Yeah, behind.
Oh, sorry.
I have severe COPD, emphysema. I'm on, and there's
Very good. Yeah.
I just wanted to ask about the Ohtuvayre.
Okay. Ohtuvayre, as I said, medication now is unique on its own. And it targets the inflammatory at the inflammatory level of the airways, decreasing the mucus production and the inflammation. That you have already a chronic fixed inflammation there that develop over time. Anything, anyway, adds to that. A cold, an environment, and so that's kind of restricting that inflammation from keep on happening or developing on its own because it's a cascade of inflammation that keeps on feeding itself. Of course, if you smoke, then it's worse. So Ohtuvayre targets that pathway, and yes, most of the patients notice improvement in the mucus clearance, improvement on the symptoms, and decreasing in the shortness of breath. So it's definitely indicated when you're optimized and you still have symptoms. Sometimes it's difficult for some insurance to get it approved. Let's say that you are already very good, optimized with all these medications. If you still have exacerbations, then you still have the injections, the biologics, to consider as a next step when you get Dupixent or Nucala nowadays approved. There are others, as I said before, already approved, waiting for FDA approval. That works also on different pathways of inflammation to also minimize exacerbations and inflammation and daily symptoms.
How effective are they finding the biologics like Nucala?
Yeah, the data is a little bit borderline for Nucala, to tell you the truth, but it still show that those patients with elevated eosinophil count, there is a decrease in exacerbations. Dupixent has been proved in asthma patients to improve secretions clearance. So but they need a eosinophil count a little bit higher of 200. So I tried, if the patient is above 200, to definitely go for Dupixent, even though the mucus clearance has not been proven COPD. It's the same mechanism of action. So I try to do Dupixent if that's the case. But sometimes we also have to go with what insurance approves. And again, there are other markers of inflammation now for people that have even higher eosinophil count, more than 300. That will be some of the markers, some IL-5s, like the pemokimab, which is an injection every 6 months, that is approved already for COPD, but it has been, for asthma every 6 months, but is already in process to evaluation for COPD patients with higher eosinophil count. We are doing, for example, one of those studies right now. We're participating in one of those studies. There is also other markers, the TSLP, I mean, it's a letter that maybe you don't know, but in that cascade of inflammation, eosinophils are here, TSLP and IL-33 are here. Those two markers, IL-33, many companies already have a study. They are waiting for FDA approval, and TSLP is also in process of evaluation. So that could be even better in some patients because that works with a cascade of eosinophils and directly with a cascade of inflammation. So there are many options coming.
Do you have any plans to come back and talking to us about pulmonary programs?
Well, if you like it, I might prepare something down the road if Oscar needs me. That's okay.
Yeah.
This is a very elementary question, but what causes the mucus and why is it just in the back of your throat all the time?
The mucus in the back of the throat might be something else. Even though some patients said, I cough and it gets in my throat and it's difficult because the mucus is very thick. It's a thick mucus when you have chronic bronchitis. And I have patients even with asthma, but also with COPD, that we end up doing even a bronchoscopy to clear the phlegm because the patient cannot deal with it. But sometimes in the back of the throat, doesn't have to be the lungs. It could be a postnasal drip, a pharyngitis inflammation that gives you the sensation of mucus. A reflux can give you that sensation too. So it's difficult to tell you in the back of the throat, but the mucus production in the lungs is because that injury in the airways creates swelling and inflammation of the mucosa, and with that, more mucus forming, and that's why you increase more mucus. And then you get infection, more inflammation, more mucus forming. It's a cycle of worsening. Yeah.
I got a question. I'm sorry. I got a question in reference to this as well. And it's one of the patients lately, last week, asked me in reference to that, about the mucus, and how can the person spell that? I know that Mark, it's promoting his vest. How good is that vest to help the patients to expel all those
I'll
mucus?
tell you, because the mucus is a problem of the airways. Over time, even a patient with COPD can develop bronchiectasis, definitely develop this chronic bronchitis, and have that mucus problem because of the muscles weakness. Vest is a very good addition to help with the vibration to bring out the phlegm. I try to avoid, though, in patients with very bad bullous emphysema, just because that vibration strength on those patients with those bolts of air, then you have a risk of injury the lung and create too much pressure and literally pop the lung. But that's in patients with bullous emphysema. Patients that don't have bullous emphysema, chronic bronchitis with difficult of muscle to help with the secretions is very helpful.
Another question that I do have is in reference to the valve, the treatment with the valve that
Mhm.
they put it on.
Mhm.
How effective is for COPD patients?
Okay, the statistics show that it helps. Personally, I have my, not every patient I think is good for it. I have a couple patients that had the valve and they end up with severe complications and we needed to remove the valve. But still, there are a couple patients that I have that are doing very good. So I kind of discuss the good and the bad with every patient. At the end, we'll do what they decide. But by statistically, it's supposed to, again, without going into the OR and get a piece of your lung out, decrease of that piece of the lung where you close it, and that gives you more chance for the other lung to really work better. There is a,
If you have more than one lung disease, how do you know where the exacerbation is coming from?
I'm sorry, if you have more than one disease?
You have more than one lung disease. Which one is giving you the exacerbation?
Okay, that's a problem. You need to treat everybody. Because I have patients, like today, for example, before coming here, I have a patient, very severe COPD in oxygen. He, over time, has very bad emphysema, and yet he has developed a little bit of fibrosis in the bottom of the lungs, like can't show overall from the smoking too, and he has developed bronchiectasis. So we try to treat bronchiectasis with a new medication, Brinsupri, because we cannot give him a vest. He has very bullous emphysema. Treat the COPD the best you can, and attack that exacerbation as soon as it comes, because right at the beginning might make a big difference, and then maybe avoid that patient to end up in the hospital. But yes, you have to treat all of them.
Okay, when you're talking about the valve, are you talking about the Zephyr?
Zephyr valve, yes.
Okay, I was a perfect candidate for the Zephyr. They took me into surgery, they put me under, I went in, and they brought me right back out. The bottom of my lung was too mushy. What causes that?
Okay, it's different causes for that. Sometimes there are so much damage that the mucosa of the airways become very frail. Like I have done bronchoscopies in patients with COPD, and as soon as you're just suction, they bleed. It's like they are angry. They are very inflamed. Sometimes there are chronic infections living in your lungs. You don't give it to anybody, but they are there. They're not supposed to be there. But once they establish, it's difficult to get rid of them. And that's another problem. So, and then it depends, I guess, of the way your body responds to the inflammation. But yes,
Well, that
probably you had that frail airway type of thing that I'm telling you, just suctioning the phlegm, it gets like damaged. It's almost like a onion, skin, very thin and very, very red and very angry.
will that get better and heal itself, or will it always be that way?
Definitely with medications and definitely with evaluation of infections, I have seen some improvements.
Okay, my other question is, in the morning I can get up and shower and do my stuff, make my bed, and I walk in the front room and I can't breathe. But I take my oxygen and it's 94 and I can't breathe.
Yes,
So
but
why is my oxygen 94 but I can't breathe?
yes, because the thing is, even though oxygen goes down over time with severe COPD, you still can have symptoms and still your lungs is managing to interact with the blood gases. And I'll tell you why. When you do exercise you're already hyperventilated. When you do exercise, any person, even a person with normal lungs, your breathing becomes more shallow because when you breathe in, it's faster than when you breathe out. And so now you are exercising, your breathing have to catch up with the heart rate to get more oxygen to the muscles to keep on doing exercise. And that's what is called physiologic hyperinflation. You get air, the air doesn't come around, so any person, even an athlete, will breathe more shallow and faster. The difference is that person have that capacity to, from this normal capacity, work with this one. The person that is already full of air, which already breathing with this capacity, now needs to breathe with this one. You cannot catch up with that, and it's a dynamic hyperinflation. And you feel like, wait, I need to wait, normalize my breathing, get better, and they keep on going because of that dynamic function of the physiology of the COPD. Yeah, you're welcome.
Well, I don't have a question, but I did want to say, what an awesome demonstration you gave us. So much wealth of information. I mean, it's just unbelievable.
Oh, thank you.
All the stuff that we were exposed to. Thank
Yeah.
you very much. That's very, very, I mean, knowledge is power. And
Yeah.
so you just gave us a great deal of knowledge to
Well, I'm
moving
glad.
forward.
Thank you so much. Thank you. Yeah.
I want to let everybody know also too, and I want to put Dr. Lisette Delgado on the spot, that she does have the clinical treatment for clinical trials. There is a lot of clinical trials that she is promoting right now, that she's using right now. So by all means, anybody that wants to go and participate can contact.
I brought some.
I'll be passing out, for anyone who's interested, I'll be passing out some business cards. You guys can email us, or you can contact us. There's 3 other coordinators alongside myself that you can speak to, and they will explain to you what
we're
trials
doing.
we have available, and we can schedule for a time for you to come in. We can also email you the informed consent forms.
So you can read about it.
Yeah, which will explain basically a breakdown of the trials, how long they'll last, what you'll be doing, and such and such. So if anyone is interested, I'll go around at the end and I'll hand out some business cards.
Yeah, we have bronchiectasis, COPD. We're doing some studies for patients with no diabetes, but obesity with obstructive sleep apnea. We're doing interstitial lung disease, fibrosis associated to scleroderma, associated to collagen vascular disease like rheumatoid arthritis. We're doing a new study for a new albuterol for asthma. And another diabetes for weight loss for type 2 diabetes. Yeah, Ventolin, I say. So there are many, so you can look in the website.
Any clinical trials for?
Possible to get a copy of your presentation?
Yes, I will provide.
Oscar can do. Yes.
I will email the presentation.
Yeah.
Yes.
I did it from.
So much information.
Okay, yeah, I know. But I wanted just to give you everything. If I go too much in detail, it's even more deep than that. But yeah. Okay.
Coming from a different direction, do you have a similar presentation of pulmonary fibrosis?
I did this one from scratch. I can prepare one from scratch. I don't have it, but I can prepare it.
We will have one with pulmonary fibrosis.
Okay.
Now, for pulmonary fibrosis, are you doing any studies right now?
Pulmonary fibrosis, but no idiopathic, related to inflammatory diseases like rheumatoid arthritis, lupus, myositis, scleroderma, anything related to inflammatory diseases, pulmonary fibrosis, yes.
Perfect. Anybody else got any questions for Dr. Sanchez?
Yeah, okay. Está bonito. Yo sé. Te pongo aquí un
Anybody
ejemplo
else?
aquí, mírenlo aquí caminando.
Well, thank you so much,
Thank
everybody.
you very much.
Thank you, Dr. Lisette, for your presentation. I really do appreciate the time that you spend with us. I know that you're always busy. I know you're always on the run. Make sure that you prepare your next presentation.
Okay.
We look forward for another presentation.
Thank you, Oscar. Thank you for the opportunity. Thank you for being here. Thank you.
Thank you for being here, participating with this.
Dale,
Your
que nos tenemos que ir.
participation makes a big difference for all of us. Okay?
Okay. Sorry.
Gracias.
No, por nada. Gracias por la oportunidad. Porque...
Créame que sí. Y le voy a poner los estudios clínicos y todo.
Muchas gracias.
They're gonna put it on.
Okay.